Wellness, career, service, whole you. Insights on living a balanced, purposeful life.
Hello and welcome to Whole You TV. I'm Shannon O'Brien. In these discussions, we explore how to pursue our life's work and live a balanced, purposeful life. We dive into topics of wellness of mind, body, and spirit, career, and service. And today's topic is about wellness of body, and specifically focuses on achieving and maintaining a healthy weight. And to further enlighten us on this topic, I'm excited to welcome Dr. Fatima Cody Stanford. Dr. Stanford is an obesity medicine physician at Massachusetts General Hospital and Harvard Medical School. Dr. Stanford received her BS and MPH from Emory University as an MLK scholar, her MD from the Medical College of Georgia School of Medicine as a Stoney Scholar, and her MPA from the Harvard Kennedy School of Government as a Zuckerman Fellow in the Harvard Center for Public Leadership. She completed her Obesity Medicine and Nutrition Fellowship at MGH HMS after completing her Internal Medicine and Pediatrics residency at the University of South Carolina. She has served as a Health Communications Fellow at the CDC and as a Behavioral Sciences intern at the American Cancer Society. Upon completion of her MPH, she received the Gold Congressional Award, the highest honor that Congress bestows upon America's youth. Dr. Stanford has completed a medicine and media internship at the Discovery Channel, an American Medical Association AMA Foundation Leadership Award recipient in 2005, an AMA Paul Ambrose Award for National Leadership. She was selected for the AMA Inspirational Physician Award in 2015. The American College of Physicians, ACP, selected her as the 2013 recipient of the Joseph E. Johnson Leadership Award, and the Massachusetts ACP selected her for the Young Leadership Award in 2015. She is the 2017 recipient of the Harvard Medical School Amos Diversity Award and Massachusetts Medical Society Award for Women's Health. She is the 2019 recipient of the Massachusetts Medical Society Suffolk Community Clinician of the Year. And believe it or not, that's just the abridged version of her bio. So you can imagine how excited I am to welcome Dr. Fatima Cody Stanford. Dr. Stanford, thank you so much for spending time with us today.
Thanks for having me. I'm excited to be here.
So you've clearly spent a lot of time focusing on these issues of obesity and weight management, but I'm interested to know how you first got started in focusing on this particular path.
Well, I would say that my path to being an obesity medicine physician was definitely circuitous. So it wasn't something that I immediately thought about if you go back with the number of years that I've kind of gone through training and being in practice. This was not a field of medicine that one could even actually seek. Obesity medicine is a relatively new field. The first board certification occurred in just 2012. So when you look at that, it wasn't something that you could really think about in terms of a field or path. But if I think about my work and my interest in this space, it started pretty early. And I'm going to go back to my time in the School of Public Health when all of the projects that I was working on, and I finished my MPH back in 2001, so a few years ago, but all the projects that I worked at during that time were really focused on addressing issues of overweight and obesity in the African American population in Atlanta, Georgia, which is my hometown. So there were several projects that I was involved in. One was called Healthy Body, Healthy Spirit. And that project was specifically looking at weight and weight regulation in African American church-going populations in the Atlanta area. There was another project that I was involved in called Go Girls, like Go Girl, and it was a project specifically focused on overweight and obesity within African American adolescent girls. And then finally, there was a program that didn't have a fancy or cute name that was specifically dealing with the WIC population, so the Women, Infants, and Children's Program, in which I served as their fitness coordinator, which I think they may not have liked because I'm known to be pretty tough in my fitness pursuits. But so with all of that work, I think there's a common thread and theme between that work. So what you can see is that obesity exists. 40% of the US adult population does have the disease of obesity, and another 20% of the pediatric population. So when we look at this, this is not a shabby problem, and actually is by far the #1 chronic disease, both here in the United States and it's pandemic throughout the world, such that 10% of the world's population does have the disease of obesity. I became particularly interested in this work because of the disparities that exist amongst African American women and with regards to obesity. So, for example, I just gave you the numbers. About 40% of the adult population has obesity in the United States, whereas 60% of African American women have obesity, and another 20% have overweight, which means that 80% of African American women in the United States, based upon the guidelines that we utilize, which are based upon the World Health Organization definition, based on body mass index. So if you have a body mass index that's greater than or equal to 30, that is considered to have obesity, and a BMI of greater than or equal to 25 it means that we're classified as having overweight. So I was particularly intrigued by this. 80% of African American women, this is the cohort that I obviously belong to. And so part of what drove me to this work, I guess my early interest in this work was trying to discern why is this disproportionately more impactful within the African American community, but regardless of looking at the impact on this particular racial ethnic group, that is still such a pervasive issue in all populations. So I think that when we look at this in medicine, that there is no area of medicine in which you will not deal with patients that struggle with their weight. And I think if we think about our individual journeys throughout our lives, that even if we don't have necessarily these definitions of overweight and obesity by clinical definitions, there may have been times when we noticed that we gained weight. Maybe it was something that was secondary to behavior change, but maybe there were things that were outside of our realm of control, but we were still blamed for our struggle. And so my desire to do this work is really to explain, to understand, but also to explain to the general public and to my patients that a lot of this isn't your fault. And I'm here to assist you in achieving the happiest and healthiest weight for you.
Seems like we're obsessed with weight, especially in the United States. We're obsessed with weight, our relationship with food, our relationship with exercise and fitness. My friends, my peers seem to always be talking about it or struggling with it. What have you seen with your patients as you tackled this work? What are some of the challenges that come up?
The first thing I do is kind of dispel this myth that it's all about diet and exercise. People want to simplify weight and weight regulation to just those two components. And I think the reason we do that is because if we look at what's being taught even to physicians in medical schools, what is being taught is so minimal and so inaccurate that that's all we do know. And while diet and exercise are important pieces of the puzzle, I like to look at the broader scope of potential things that could have led to a person struggling with their weight. And some of these things may be sleep quality and duration, which plays a large role in how the brain regulates weight. We can look at circadian rhythm disturbances, meaning are you up in the middle of the night when you really should be asleep, and vice versa. So even if you make no changes in what you're eating and or your exercise, you might notice significant shifts in weight if you're a night shift worker versus a day shift worker. And day shift workers presume that those night people, they just do a bad job. No, the brain is very unhappy, and the brain is what regulates our weight. So the brain wants to be awake when it's bright outside, and it wants to be asleep when it's dark outside. But our environment has become obesogenic. What I mean by that is that our environment supports these things that support obesity. So if I want to communicate with my colleagues that are in Greece in the middle of the night when I really should be asleep, I am awarded for that communication. Oh my goodness, look at our colleague in the United States. She's working on that paper and wow, she's gotten it back to us. And then I get another publication and then they give me some award and that's great. But what I'm not doing is looking at my overall health. If we take just you and I, Shannon, back to our childhood, we couldn't do that. There wasn't a way for me to communicate with the people in Greece in the middle of the night, right? So we had to align a time that fit for us. Probably didn't want to call because that long distance call would be quite expensive. Our communication may have been a bit more along the lines of a snail mail, right? A U.S. Postal Service to their communications to get something done, and maybe the pace of communication and work may have been hindered by that, but we weren't up looking at TV at 12. And, I don't know if you remember, but you guys remember when the different bands of color used to come on the TV because the stations would stop with any material on TV. But now if we want to watch TV 24 hours a day, that light, whether you have a lovely backdrop light that changes to accommodate the fact that you're supposed to go to sleep, is still something that's not healthy for us. And so those are certain things that have changed. Medications that we as physicians prescribe to you can cause significant weight gain, but we never look at ourselves as a source of the problem. And we may prescribe the medicine, the patient gains weight, the doctor, when the patient comes back, doc, look, I gained weight. And they're like, well, no, it's something you just didn't do enough. You should have eaten less and exercised more. And so we have a lot of this kind of blame game, and we have a lot of this not understanding the complexity of weight and weight regulation. Some of it's the cards you're dealt, right? So if your mom and dad have a history of obesity, or your grandparents have a history of obesity, the likelihood that you'll struggle with weight much higher than someone that doesn't have that issue. Obesity is largely heritable. And as we have these perturbations, right, this obesogenic environment conflicting with our propensity to have obesity, it's really just the perfect storm. And so, I kind of been here in the middle of working on this perfect storm, but hoping to help people to think about this in a more holistic fashion.
Right. So some of the challenges are that people just think, oh, it's food, oh, it's exercise, but you're saying
And
it's ocean, it's our environment, it's our pace, it's the 24/7 nature of the way that we live now. So you're struggling against all of these different things rather than just if someone did exercise well, eat well, and they're so confused because they're still gaining weight.
If we look at like who my typical patient would be, I see both pediatric and adult patients. But let's look at the average patient that would seek care for their weight. That average person is going to be a postmenopausal Caucasian woman. So you're like, well, why? Why is that? Because that postmenopausal Caucasian woman has a lot of control over factors in her life. She often is the person that buys the groceries, does the cooking, is able to set her schedule to do exercise at X, Y, and Z times, often has a financial base to allow her to do these types of things. And despite all of those things, she comes to me and she's like, doc, I'm confused because I'm doing this and this and this and this and this. And according to what I've learned in the 60 years that I've been around on this earth, I should be here. And so I have to explain to them that even as you transition into menopause, we have a major shift in fat distribution, which we have no control over. We go from having a gynoid distribution of fat, which is fat in the hip, buttock, and thigh region, to an android. Yes, android like the phone. Android means male-like. So if you have an Android phone, you have a male-like phone. But it's central adiposity, which is fat that's located in the midsection. So we have that transition, and that's something that almost everybody will go through. And so they go from like, well, gosh, why is fat here that wasn't there? And it's just part of that menopausal change, that hormonal change that had nothing to do with something that you said, hey, let me sign up for that. But it's something that's part of the natural process of life. And some people have a higher level of impact of that and see significant shifts in weight. And especially that weight we carry around our midsection, that's the weight we don't want to have here. That's the weight around all of our vital organs, right? Our heart, our liver, our lungs, all the stuff that really gives us life. Whereas when we carry it in our hip, buttock, and thigh region, it's just bone muscles there, right? So not deleterious to our health. And so my goal when I'm working with that individual is, first of all, to take away a lot of that blame, because that woman is doing a lot. And yes, we may be able to modify some of these things a little further, right? Maybe we need to increase the level of whole grains or things of that sort. But those are the things that patients, by the time they get to me, a lot of times they've tackled a lot of those things. They've been waiting 9-10 months to get in to see me. And so now I might need to take it a step beyond and offer additional tools to help them achieve a healthy weight.
What are some of these resources and tools that you provide to your patients?
It's kind of like a pyramid, right? At the base of the pyramid, we do want to maximize those behavioral factors, right? Diet quality. I do not look at the number of calories. That can become obsessive. and lead to maladaptive eating behaviors and even anorexia nervosa or bulimia nervosa, which are eating disorders.
I was going to ask, sorry to interrupt you, but just to ask about Weight Watchers, would you not be a fan of that if you said you're not counting calories per se?
What I tell my patients is I want them to have more of a holistic view of food and a relationship with food that's not obsessive and counting numbers or points or calories. I want them to have a relationship with food where they understand volumetrics, meaning if I eat like a big bowl of spring mix, that's going to be very low in calories such that I don't have to count it, but it's going to be so filling that it's going to send signals to my brain that tells me, no, I'm just not really that hungry. Or if I eat a nice, broth-based soup, I may eat just like a small cup of soup. Oh my gosh, full. So picking out foods that are healthy for you, things that I can do for the rest of my life. Now, if Weight Watchers works for you and you want to be on Weight Watchers for the next 40 years, fine. I mean, if that works for you, I'm not saying that it's a bad approach per se. Not something that I would want to do for the next 30 or 40 years to go to meetings, whether it's online or in person, and count the numbers and all this stuff. I want to develop a relationship with food such that I'm able to kind of pick things that work within my palate, work with any food sensitivities or things that I have that don't require this obsession with numbers and points and cataloging and things of that sort. So stress is a contributor to weight gain, right? So just increasing stress, and if it's chronic stress, we see patients gain continuously gain weight. This obsession with this needing to count the calories and the points and things can become very stressful to people. It causes lots of anxiety, which can then lead to weight gain. So my goal is not to lead to weight gain. I want to achieve a balance such that you get into a natural rhythm of what works for you. So you might do a behavioral program in our center, for example. We have a program called Healthy Habits for Life, which is a 12-week program led by our dietitians, which does not focus at all on counting calories, but looks at the quality of your food, looks at this idea of volumetrics, looks at concepts of hunger, which is how hungry you feel between meals, satiety, how long it takes you to feel full once you start eating, and all of these types of things over those 12 weeks. And I think that patients may or may not lose, because I told you by the time a lot of times patients get to us in obesity medicine, they've done a lot of this work and now it's just kind of refining it. Maybe they need special psychological care. Maybe they had a long-term history of having an eating disorder. Persons that have eating disorders early in life actually have a much higher likelihood of developing obesity. The way that I would explain that is that the hypothalamus, which is a part of our brain that regulates our weight, tries to overcome and overcompensate with what went wrong previously, as we meaning the person that had the eating disorder, tried to really restrict and overcomes that, and then leads itself in kind of really an opposite direction. So all of these things are important. So if that's the case, then behavioral programs may not work until we get those psychological issues under wrap. Some people have body dysmorphic disorder. They may see themselves as much larger or even much smaller than they actually are. And when that happens, they have weight concordance or discordance. What I find, I published a whole study looking at persons that have severe obesity versus those that have mild obesity. And what I found in this national study was that persons that have severe obesity usually want minimal intervention to help achieve a healthy weight, meaning minimal tools, mostly behavior. Whereas people that have mild obesity usually kind of want all the tools. Send me to surgery, doc, send me to do this, but they don't really have the severity of the obesity that needs that tool. So that's that idea of weight discordance. So you can tell us a lot that we could do. We could do medications, just like we are treating any other chronic disease process like high blood pressure, diabetes. We would use medications for those that we've maximized behavioral efforts and still struggle with weight. But if we use medications or pharmacotherapy, whatever word you want to use, these are chronic use medications. Meaning if I start you on a medication and it works for you, I'm keeping you on that medicine indefinitely. Because if I withdraw that medication or I stop that medication, what happens? You regain the weight, right? So I have to make sure that that's apparent to the individual before we endeavor down that pathway. because it's not a stop, start type of thing. The system is not very happy when we do that. Much if I would put you on high blood pressure medicine and I stop, and then your blood pressure goes up, then I have to put it on, and then it's not as well controlled, then I need to add in another medicine. It's all confusing. Some patients do need surgery, and I will send patients to surgery as young as 13, and a lot of people balk at that. And I think that's a problem in and of itself, because if a patient has severe obesity at 13, can you imagine what their life is going to be like? Not only as it relates to their health, but the opportunities that are available with them as they approach a job interview or college interview and someone sees them with 150 pounds of excess weight. Are they going to be given a fair shot? Now make them an individual that's a Black individual like myself, where there's already biases against race, and now we're going to add weight on top of that, and are we going to think they're going to get a fair shake? I would say no. And studies have shown that patients that have obesity, especially severe obesity, don't get accepted as easily in graduate programs. There have been large studies. Their ability to get employed is also compromised. And so we can tackle that early on and have a large or long-term impact on a person's life, especially an adolescent, who then can have a life where they're not experiencing the struggles that someone that waited and came into my office at 70 to get surgery. And then what that patient tells me is, I wish I'd done this 40 years ago.
Right.
So that's a long drawn out answer, but it shows you that there's multiple strategies that we might take. And I try to personalize that strategy to the individual. So not what someone does and that it seems to have the same, be similar to me, might not have a similar response, And so I have to do, unfortunately, a lot of trial and error, but I think about the best tool for the patient. And my goal is to get them, like I said, to their happiest, healthiest weight. And that's a much more of a challenge, the higher the level of obesity, for example. But it's something that I've endeavored to tackle, and I approach this with my patients as if they're my own family members. What I want for my mom, my dad, my husband, my sister. And I treat them accordingly, and we're going to work through this together. They are the leader of the team, though. I am the doctor. Yes, I have a lot of knowledge, a lot of degrees and awards, and that's great. But the work that happens with that patient doesn't happen when they're sitting there with me for their 30-minute follow-up visit. It happens when they're at home, when they're in their community, and they are leading their life. I'm just helping. I'm the helpmate, basically. I am the doctor, but they are the leader.
Right. Beautiful. I think your answer was very eye-opening for me, that you do take this holistic approach and look at someone's stress and sleep and psychological state and maybe medicine, and maybe even going as extreme as you said with surgery, if you think it is.
I'm going to change your words. I don't look at surgery as extreme. I look at it as a tool.
You said people see it as extreme.
People see it as extreme, and but I always tell them my pet peeve is that, I just don't want to do surgery. So I'm going to utilize, and I'm hoping Northeasterners are watching this. And this is kind of how I approach this thought process when I'm thinking about surgery. Say we get 12 inches of snow tonight. Mm-hmm. Do I go and remove the snow outside of my home with a teaspoon? Shannon, should I do that?
No.
Why not, Shannon?
It's going to take you a long, long time.
Okay, you could. Right? So a more appropriate tool might be what, like a bulldozer or a big truck to move it out of the way. Mm-hmm. Now, let's say I have like a 1/4 of an inch of snow. Maybe I could use a teaspoon to get it out of the way, because, it probably will melt, very quickly. So when I think about surgery, I think about using that tool to treat patients that have severe obesity. Mm-hmm. Me using the teaspoon approach, which is to put them on diet number 29, will likely not lead to any significant change when we have that degree of obesity, much like me trying to use a teaspoon to address the problem. But I need to kind of pull out the biggest tool that I have available to address it. And even then, when we go to weight loss surgery, many people still struggle with mild to moderate or even severe obesity, depending on where they started. So it's about using the right tool for the size of the problem. In the same line, a lot of times patients come in with me with, let's say, only 20 or 30 pounds of excess weight, and they want surgery. So like, get this off of me, whatever I need to do. Well, that wouldn't be the appropriate tool. It's like me trying to use a bulldozer to scoop up a half inch of snow. They're kind of like, well, there's not enough snow to scoop up. So
Right.
that's kind of how I think about that. And that's how I explain it with my patients, especially here in the New England area.
Yeah, makes a lot of
Yeah.
sense. So it sounds like even your example of people who are applying for jobs, applying for college, that these kinds of changes that you're helping them to implement can have a massive effect on their life and how people perceive them.
Absolutely.
So people who are struggling with their weight, what other kind of impact, can you give us other examples? You said that you treat your patients like your family.
Mm-hmm.
And I imagine then when your head finally hits the pillow, because your days are very, very long and you're traveling to Dallas and DC and you're always traveling somewhere, you've got such a busy schedule. But I imagine when your head hits the pillow at night, you are very proud of the work that you do and the impact that you have on these individuals.
Yeah, I really, I sometimes when a patient comes in and we've gotten to it, because I don't per se focus on the number on the scale, but I do obviously pay attention to trends. And sometimes patients have huge transformations. And, you know, it can bring me to tears. And I say, well, why am I crying and you're not crying this time?
Yeah.
But I get very excited because I know that it's not just about the number on the scale. I think, like, you can't look at you or me and say, she weighs X. I mean, I can probably guess. I mean, I'm pretty good because that's what I do, but it's not that matters. It's about how that person feels, how they're able to navigate life. I have patients. I have one gentleman who's now in his mid 60s. When I started seeing him, he's in his late 50s, and he wasn't able to fly an airplane for 30 years. He could not fit in a seat, even with the extender belt. And he flew for the first time in 30 years after we got to a different weight status. And I mean, that's something that I don't even think about when I take these flights all around. I'm just like, okay, I got another flight to take. I'm not thinking, can I fit in the seat?
Wow.
For one individual, one young woman, I call her young because I'm getting older, but she's in her late 40s. When she first came to see me, she had very, very severe obesity. Went in to get hired or went in to interview at a local retailer. Within about 45 seconds was told that she was not a good candidate for the role. Worked with me over about 4 years, got to a pretty normal weight status, went into the exact same retailer, exact same hiring manager,
Wow.
No additional education, and was offered the job within 20 seconds.
Oh my goodness.
So,
pretty woman story. Did she take the job?
She did take the job, and after she got the job and became a part of the team, she went back to address that hiring manager, who's actually a friend of hers now. She tells me, I don't know if I could be friends with that person, but she said, I just want you to know that I came in 4 years ago to this exact same place for this exact same position, and you didn't even consider me. The only thing that's changed is that I look different. I mean, obviously, yes, her medical issues are different. I'm the only one that knows how those have changed. But she wanted to let you know that, hey, this hurts, and it shows you that must have been the issue, because my gender didn't change, my race didn't change, none of these things changed. The only thing that changed that's visible is weight status. And so when we look at someone that struggles with weight, we make these judgments on how they look. We make a judgment if a patient walks down the street that may have, let's say, weighs 300 pounds. Oh, they're not trying harder. They could be doing this, or maybe they're eating this. What we may not know is maybe they were 550 pounds, and they may have done a lot, and they've got 250 pounds off. But we make this judgment or this assumption about what they have or have not done, and immediately treat them a certain way because of our preconceived notions about what they have or have not done, what their energy level must be, if they're lazy or not. And we give them these negative adjectives of being slothful and lazy and a detriment to our society, when we don't know if a person, we don't know what they've done. We don't know what their struggles have been. And we can't make those judgments if someone is walking down the street with poorly controlled diabetes they're on 5 different medicines. We just can't see it. Or if they have high blood pressure and they're on 6 medications, we can't see that either. So we can't really make that judgment because we don't know. Obesity and weight struggles are visible. And with that visibility comes our desire to judge. And our judgment is typically negative and not at all helpful to that individual that struggles with weight. Because weight stigma, when that patient experiences weight stigma, it leads to them not wanting to go and see a doctor. It leads to them, because they can face it from someone like myself. Maybe they get to the doctor's office and they don't have a chair they can sit in because there's not one adequately sized. Maybe the blood pressure cuff doesn't go around their arm. These cues, while you might say, oh gosh, well, that's not really your fault. Well, maybe it is. If I know that X percentage of patients that come here have obesity, then maybe I need to have things to accommodate my patients so that they're not immediately given these nonverbal cues that they're not welcome. And so these are things that have an important impact, and weight stigma actually does lead to poor medical outcomes. It leads to increased stress hormones in the blood, increased blood sugar, all kinds of things, increased central adiposity, that weight we hear in the midsection. Study after study consistently prove this. So when we pass our judgment, even if we feel like we're not giving a cue to individuals, they sense what we're putting out. And we need to stop and think. I think for women, and I think that women should really think about this. Many women do become pregnant and often feel uncomfortable about their weight change during pregnancy. You can't like stop the baby from growing, right? But and feel maybe uncomfortable about how they look at the end of pregnancy. And so I want, if there are women watching this, before you pass judgment on an individual that may not be pregnant, think about how you felt and how you felt in your body at that time. Would you felt comfortable if someone called you a negative name or treated you in a negative way at that time, when you already felt a little bit vulnerable about the change in your body? Well, for patients that have obesity, yes, it's not a 9-month duration of time, but imagine what that must feel like every day for 30 years.
So this negativity, this judgment is one of those added elements to this holistic
absolutely. The judgment is
cocktail of issues that are, preventing people from managing their weight.
Right.
But it sounds like you've obviously really helped so many individuals to manage their weight struggle and identify all of these different factors. Can you help our audience by sharing some resources? I know that you have a book as well that might shed some more light on this topic. Do you want to talk to the audience about how they can learn more about you and the resources you recommend?
I have a book that I just wrote that just came out here in 2019. It's called Facing Overweight and Obesity, a complete guide for children and adults, which means I wrote this for everyone. 358 pages of information that really spans everything from learning how to deal with weight bias, learning how the media influences our thoughts about weight and weight struggles, medical conditions associated with weight struggles, bad diets that have come and gone, what their pluses and mostly minuses are. And it really just covers a lot of different things. So I see it as a go-to resource for patients or persons that are just interested in learning, like, what is all of this? Why? What is she talking about? The brain regulates weight? She doesn't know what she's talking about. Yes, I do, by the way. Subscribers, it is free for, if you're unlimited Kindle subscriber on Amazon, or others that want, a paper copy because you don't want to disturb that circadian signal in your brain by looking at a light. There is a paper copy, and I do think it, not just because I wrote it, I really do think overall we tried to tackle issues that span behavior, looking at all the medications that are currently available, that are approved by the FDA, and surgical interventions and options if that's indeed the appropriate strategy for you. And just to know, because a lot of information that's out there on social media, unfortunately, is misinformation. A lot of information that physicians might convey, unfortunately, may be short of what really categorizes this really complex. And I would say this is probably one of the most complex, if not the most complex, medical problem for us to figure out, because there's so many factors that play a role. So that's one thing. I'd say find me on LinkedIn. I try to post regularly if I'm giving a talk or things of that sort. I try to keep posted if there's a talk that's in your area, because I'm in most areas in the US and do travel abroad quite a bit. I don't always put it up quickly enough for you to know in advance. You may see it afterwards and be like, gosh, I was in that city. I can stream that talk. And I do apologize for that, but I do try to catalog it at least after it's occurred. You can find me on Twitter also. I think Whole You, which is hosting me, will make sure that those links are available to you. The other place is my website. So if you just, believe it or not, if you Google Harvard Fatima, everything about me comes up. So my whole Harvard website comes up with long lectures that I give, and I try to make them exciting. So if you want to really look and learn all about me through those venues, that's fine. But my goal isn't for you to just learn about me. I think that that's one piece of the puzzle. My goal is for you to be the happiest, healthiest self you can be at the happiest, healthiest weight for you. And if learning about me helps you with that, great. But me, I'm just the vehicle that delivers this information. And hopefully this information will provide you with different insights so that you can begin to think about yourself and your family and your friends and stop judging. That bias is hurtful, is harmful. Weight bias is the only bias that has continued to climb in the United States. Race bias, they say, I don't completely believe it, but it's starting to trend downwards, whereas weight bias has continued to increase. And so this is real. And you've probably done it. I've done it, unfortunately. And I would say I don't do it I try not to do it as a physician. I would say, if I look to my early life, I can think of instances that may have caused harm to individuals. And I can't take that back. So.
Well, hopefully people who have viewed this and listened to you and listened to the wisdom that you've shared will rethink their judgments of other people and will educate themselves and also investigate their own weight management and see if any of these extra factors that they might not be thinking about are affecting their weight, their size, the way that they feel.
And and if you can find someone like the other tool, that you can use the American Board of Obesity Medicine to find people that are actually obesity medicine specialists. There are only a few of us that are fellowship trained in the country, 12 of us actually to be exact.
Wow.
But there are, I think, about over 2,000 that are actually board certified now, people that went and took courses taught by individuals like myself and got enough credits to be able to sit for the examination. And of course, there's some variation in the knowledge base of someone that did a 3-year fellowship versus maybe someone that didn't, but I would say that they are still committed to this work and are there to provide resources in their respective locations. The American Board of Obesity Medicine does have, you can search diplomats, however you want to say it, by state and see if one is in your area. But I think that we're here to help, and overall, that's our goal. Our strategy is to get you to the happiest, healthy self for the distance, right? Not to just put you in a cute diet, lose rapidly, and then you regain it all, because that's what happens. Right. My goal is to get you to lose weight and maintain that weight indefinitely.
Beautiful. Yeah. Thank you, Dr. Stanford. Thank you so much for your time.
Absolutely. Thanks for having me. I really had a fun time with you, Shannon.
For more insights on wellness, career, and service, check out wholeyou.info/blog. You may also want to schedule a work-life balance advising session, which you can do over at www.wholeyou.info. Thanks for listening, and I'm wishing you a balanced, purposeful day.